Welcome. My name is Jasmine Kamboj, and I'm a medical oncologist and hematologist in the state of Minnesota and your host for the day on Empowering Oncologists. Before we dive in on the podcast, a disclaimer. The views on the podcast are in individuals and in no way are views from an institution, guidelines, or organization. For our session today, we have a very special guest, Dr. John Sargent, who is the co-founder of the Broadreach Group, dedicated to advancing fourth industrial revolution technologies to promote global health equity. Dr. Sargent holds an undergrad degree from Dartmouth College, a master's degree in social and cultural anthropology from Oxford University, and a doctor of medicine from Harvard Medical School. Dr. Sargent has provided counsel to prominent corporations like Merck, Mercedes-Benz, Microsoft, and governments across sub-Saharan Africa. He is presented at the World Economic Forum's annual meeting, served on the board of Dartmouth's Center for Global Health Equity. When not working, he engages in American flag football, history fiction reading, and skiing. Dr. Sargent, welcome and thank you for being here.
Thank you so much. It's a pleasure to be here today.
John, you've traveled the world. You were born in Taiwan and you've lived everywhere essentially. Tell us a little bit about your journey.
Yeah, so I think actually my background has a lot of, is probably the main reason why I'm actually in global health. So I'm actually half Taiwanese. I was born in Taipei. My mother was Taiwanese, dad American. And because of my dad's job, he moved around everywhere, every few years. And so when I grew up, I sort of grew up in two different cultures, sort of my mom's culture from Taiwan, my dad's American culture, and I never really quite fit in. I didn't really quite look like my relatives on my mom's side or the relatives on my dad's side. So it was a really interesting way to grow up because I was always jumping in between cultures. And as I grew up, I always had this really big interest in learning as much about different cultures, different ways of viewing the world, of living. And so, when I was in undergrad, of course, having an Asian mom, I was pre-med. And so as pre-med, but I also was very interested in travel and different cultures. And so that actually led to my actually going to Africa as an undergraduate working in a refugee camp. And it completely opened up a whole new world. And I realized that public health and global health was where I wanted to end up. And I think since then I've lived in Africa, I've lived in Europe, all over the US. I currently live in Switzerland, but travel quite a bit around the world.
So your upbringing has a lot to do with what you're doing right now in terms of your professional life. Wonderful.
Definitely, yeah.
Okay, John. So we'll start with the basics. I have to be honest. I was intrigued with the term fourth industrial technologies. What exactly is that?
Yeah. So fourth industrial revolution is a term that was developed by Klaus Schwab, who was one of the founders of the World Economic Forum. And he wrote a book probably 5-6 years ago now, where he talked about that we are going into this really interesting phase in the history of humanity where technology, whether it's information technology with AI or biotech or all aspects of technology are going through this sort of hyper warp speed development. And the idea is that within the next 10, 15, 20 years, life is going to look drastically different from where it was. We need to be prepared to figure out how to harness these technologies to hopefully make life better for everyone on this world.
Absolutely. So where does, tell us about the Broadreach Group and its vision and how did you find it and tell us about that.
Yeah. So Broadreach started in 2003. So my best friend, Ernest Darko, and I from medical school, and we're still best friends today, founded the company to start working in Africa, helping governments address HIV/AIDS. And sort of the backdrop to that is, Ernest and I, best friends from medical school, we sort of pushed each other in medical school, and we both realized that we had a passion for global health and public health. And so both of us actually never did our residencies. So I had the opportunity to do my residency in internal medicine. I decided not to do it, and I decided to spend time as a management consultant. Ernest did the same thing. And our whole idea was that we needed to learn about business and operations and management if you wanted to go into public healthcare. And so that's what we did. And then Ernest was interesting on a McKinsey project. This was around 2002. The world was waking up to this horrendous HIV pandemic that was hitting Africa. And so McKinsey did this really interesting pro bono study to help the country of Botswana figure out how they were going to deal with it. Ernest called me. I flew down from the US. We quit our jobs. We said, look, let's open up our own little consulting firm
Mm-hmm.
And this was before this phrase of social entrepreneur, social enterprise was around. We just said, let's be a consulting firm. Let's help governments,
Mm-hmm.
donors, NGOs, anybody who wants to help improve access to HIV medicines. We'll help them. So we opened up this little tiny consulting shop, and very quickly we won a large USAID contract. So this is when there's a program called PEPFAR, the
Mm-hmm.
President's Emergency Plan for AIDS Relief, came in 2003, and we won a big project in South Africa a couple of years later. And the type of work we did was advise governments or NGOs or nonprofit hospital groups across Africa on how they
Right.
can improve HIV care. And
Mm-hmm.
so then that quickly started developing into technology. And this is where fourth industrial revolution comes in, because we realized in running all these programs,
Mm-hmm.
you're working in super resource poor settings. You don't know a
Absolutely.
lot about what's happening across, hundreds of hospitals, across
Right.
populations of patients with tuberculosis or HIV. And so we started, building technology solutions to help us better understand what was going on and
Right.
manage the outcomes. So that's sort of the background. And, 22, almost 23 years later,
Mm-hmm.
we're still at it.
How has this been funded? Like, tell us about some funding challenges around utilizing digital health technologies in these countries who are unfortunately already, fighting with funding crunches and stuff like that.
Yeah, that's a great question. So the challenge of working, and we've mostly worked in sub-Saharan Africa, but we've worked in other LMICs, lower middle income countries around the world. And, the big challenge is this: you've got a lot of need,
Mm-hmm.
but very little ability to pay and deal with it. And
Yeah.
so, for, the last 40, 50, 60 years,
Mm-hmm.
many of these countries are assisted by donors, US government, EU,
Mm-hmm.
um, all sorts of countries, private foundations, etc.
Right.
And so, I think for us, what we realized was, predominantly in sub-Saharan Africa, you have roughly zero point 0.2 doctors for every 1,000 patients. To give you a frame of reference, US, we have 2.6. So over a 10x difference. Um, the typical patient in sub-Saharan Africa, about $100 per year is spent on that patient, whereas in the US, it's probably 13 or so $1,000. So big disparity. So what we found very early on in the work is that any dollar you waste in these
Mm-hmm.
in these settings, it means somebody's not going to get treatment. And
Mm-hmm.
so this idea of trying to use technology to bring the data together, understanding what's happening, help make better management decisions with that money, means that more people can get access to healthcare. And
Mm-hmm.
so, we're in challenging times right now because a lot of our technology and the work we do
Mm-hmm.
does get direct support from donors. And we're in a time right now where donors are pulling back significantly around the world. So I don't know what's going to happen, but my hope is, again, with this idea of technology rapidly increasing, costs going down, we're going to try to find new ways and new models that are going to be affordable, because we need these technologies to better manage these health systems, because ultimately we want to help as
Absolutely.
many people as possible.
So did I hear you right? You said 0.2 physicians for every 1,000 people in Africa?
Yeah, in
And
sub-Saharan
then
Africa, yes.
and then we are spending $100 for a patient care per year in Africa, versus sub-Saharan Africa, versus $13,000 in the States.
Yeah, on average. Yeah.
Wow.
And so it
Those
means,
are fascinating.
oncology doesn't happen in many places where we work.
Right.
It just doesn't.
Right. Right. Those are some very fascinating numbers. John, in oncology, we are talking a whole lot about precision medicine, precision oncology, right? Targeted therapies, biomarker based therapies. Your group has, however, coined the term precision management, or is utilizing the term. Tell us about what is precision management and how are you using that in Africa versus other areas in the world?
Yeah. So as a follow-on to the prior question, so, what we found was, we're doing big consulting projects, trying to improve health systems, train doctors, nurses, all sorts of things. But there's so little resources that anything that's wasted means that patients don't
Yeah.
get care. So we started building this technology because what we found out, we call it Vantage. And what we
Mm-hmm.
started doing was that, give you a real example, we were working on a project that helped about 1,000 government hospitals and clinics in South Africa
Okay.
improve their care for HIV and tuberculosis patients. The
Mm-hmm.
challenge was we never knew, are we doing a good job or a bad job? We didn't know that till 3 or 4 months after the fact, when we got some reports to say, hey, this many people dropped off treatment, or your average viral load suppression rates, or whatever. And it was very frustrating because you found out 3 months after the fact, a lot of money has been wasted, or resources not effectively utilized,
Right.
and probably a lot of patients that we could have helped. So
Mm-hmm.
we started saying, okay, can we start stitching together different data sources in real
Mm-hmm.
time, whether it's giving people apps to collect data in these government clinics, or tap into different systems and start just putting it together, and maybe on a weekly basis, monthly basis, get a better sense of what's happening. Is Clinic A doing better than Clinic B? If so,
Mm-hmm.
why? Is it a staffing issue? Is it a stock out issue? What are those issues? And so over
Right.
time, over the last 10 years, we've built a really significant platform. So we're a
Mm-hmm.
Microsoft partner. Everything's built on Azure. And,
Mm-hmm.
and a couple of things about that. So the first use case was to stitch data together and just sort of see what was happening. But what we realized was there's lots of different use cases. There's a nurse manager in a rural
Mm-hmm.
clinic on a Monday morning.
Mm-hmm.
She's not hitting her HIV testing numbers. Why is that? And how do we help her do the right things? Maybe it's assigning an
Right.
extra nurse to the testing
Mm-hmm.
ward. Maybe it's enacting a community-based testing campaign and giving her the
Mm-hmm.
tool to do that. So what we
Mm-hmm.
realized was that we needed a platform and not just a solution. And so what we built today, I sort of describe it as a cool Lego set where we've got all these different pieces. And if you need to help a country monitor all their hospitals, you can put those
Mm-hmm.
pieces together and look at that. If you
Right.
need to run a adherence support program for patients
Mm-hmm.
on antiretroviral therapy, we can
Yeah.
do that. We can run machine learning algorithms, identify who's at high risk for stopping the meds, and then follow up with them. And we sort of do everything in between. And so
Mm-hmm.
today, think about the Vantage platform as this cool Lego set, and we deploy different type solutions around the world. So to give you,
Yeah.
two concrete examples, in Nigeria, we've got two interesting projects where we're at the federal level, and
Mm-hmm.
we are monitoring the performance of all government hospitals and clinics as it relates to
Mm-hmm.
tuberculosis and HIV. And that
Okay.
comes from donor funding through the Global Fund.
Mm-hmm.
Another example is actually in oncology. So we recently finished up a really interesting NIH project with Baylor College of Medicine and Texas Children's Hospital, where Baylor and Texas Children's Hospital were setting up centers of excellence for Burkitt's lymphoma. And so we
Got
were
it.
working in Malawi and using the same exact technology, but configured a
Mm-hmm.
solution to monitor how closely were we
Mm-hmm.
adhering to the clinical protocol for each of the patients, and then using that as a tool
Got it.
to help the clinicians, and this is in Malawi, learn sort of when they deviated from the pathway, why, what happened. So those are really different use cases that we
Yeah.
deploy, but it's all with this idea that
You're right.
technology, AI, can
Right.
ultimately improve performance, resource utilization, and ultimately health outcomes.
That is terrific. So you created a precision management technology for utilization in sub-Saharan Africa and other LMICs. But now that technology can also be used in bigger centers like Texas Children and Baylor. I mean, these are some really big names. I actually trained at Baylor myself.
Oh,
So,
great. Yeah, it's a great institution.
John, you've also worked with a lot of community oncology practices in the US. And so that is something obviously near and dear to my heart because I'm a community oncologist myself. Tell us, how has that relationship played out for you, and how has that benefited professionals and patients in community oncology?
Yeah, so it's been a really interesting journey. So, like, I'm originally an American, worked in Africa, and now I've come full circle back to the US. So, I think when COVID happened, and
Mm-hmm.
people again in the US were starting to see, wow, there actually are a lot of health disparities
Mm-hmm.
going on.
Mm-hmm.
Um, And so my co-founder, Ernest, and I started asking a question. We brought on a new CEO to oversee the group because we'd grown so large.
Mm-hmm.
And we were going through a 5-year strategy. And the question we asked was, look, we're a social enterprise. Our whole aim is to improve access to healthcare using innovation. What have we learned working in some of the toughest settings in the world? What have we learned? What capabilities have we built within the Vantage platform that we could help in the
Right.
US? And around
Right.
that time, I actually got a cold call from a community oncology practice in Texas, oncology consultants in Houston.
Mm-hmm.
And they said, we saw an interesting article about how you're using technology to help HIV patients in Africa. Is there something you could do with us? And so we started talking to them, and they said, well, we've got lots of patients in community oncology that have a lot of social determinants of health barriers. They may
Right.
not have reliable transportation. They may not have reliable nutrition, housing,
Mhm.
underinsured, and that
Mhm.
impacts on their treatment adherence and treatment outcomes or the ultimate
Mhm.
health outcomes.
Right.
And we've got community healthcare workers, we've got nurses, and they're catching patients when they miss an appointment, and then we're trying to then arrange a taxi voucher or do whatever. Can you use
Mhm.
your technology to help
Mhm.
manage these patients better and help us
Mhm.
catch these issues before they become an issue? And so
Mhm.
that started a really interesting partnership where we took the
Mhm.
technology, we went to Texas, and we said, okay, what does a care manager do? Uh, how do you identify these issues? And then we built this solution called Social Health 360, which Oncology Consultants was sort of the first sort of pilot
Mhm.
case. Today, we're in 9 states
Mhm.
and rolling out with American Oncology Network.
Mhm.
And now with the advent of certain value-based care programs like principal illness navigation for Medicare,
Mhm.
there is reimbursement starting to happen. So having a solution like this where you can document, track, audit what you're doing to help a patient and then ultimately get reimbursed, I think is a great win-win for everybody.
Absolutely.
The last thing I'd just say is that it's gone to a really interesting point where
Mhm.
we're now in a partnership with Gilead, because
Mm.
Gilead has a lot of interest as well in
Mhm.
addressing health disparities as it relates to oncology patients. And
Mhm.
we're doing an evaluation of
Mhm.
this technology, Social Health 360, built on the Vantage platform, and asking the question, is it really improving patient outcomes? Is it really reducing costs? Is it making life better for navigators? And so we're doing that in partnership with Gilead and actually Dartmouth Institute for Health Policy. So that just kicked off, and we're hopefully going to have some interesting data in the next couple of years. And I'm
Yeah.
hoping that data can influence policymakers and
Absolutely.
insurers to say, let's address these
Right.
social upstream issues because it really impacts, as any practicing physician knows, it impacts outcomes.
By any chance, do you have any practice in Minnesota, in the state of Minnesota, that you partner with?
Not yet,
Not
but
yet.
hopefully, yeah, hopefully soon.
Yes. Yeah. Your concepts sound fascinating, so that's great. Dr. Sargent, you garnered prestigious recognitions, and several of them, like the World Economic Forum's Social Entrepreneur of the Year Award in 2015, the Visionary Leadership Award in Healthcare, inclusion in the top 40 under 40 leaders in development. What is your key to success? Any key takeaways for the younger generations?
Yeah, so that 40 under 40 was 15 years ago. So I'm 54 now, so that happened a long time ago. But what I would say, my advice is, so we live in a day and age where a lot of people like to post lots of things.
Mhm.
It's we never went into this to get awards. We went into this really as sort of a calling and a life's mission.
Mhm. Mhm.
And I think for us, and the advice I'd give to anyone is follow that life's calling and follow what your mission is and what you're passionate about and what your contribution to the world is. And I think those things will take care of themselves.
Wonderful, beautiful. My next question is kind of a piggyback to this question. One advice you would give to yourself of 10 years ago or 20 years ago?
Ooh, that's a good one. I think patience.
Okay.
So, all of us, especially if you go through pre-med medical school, you're all type A and you just want to achieve goals as quickly as possible. And I think as I've reflected on this journey with being an entrepreneur, a lot of the biggest so you might have plans and you might want to push really hard
Mhm.
and you become so focused on that that
Mhm.
you actually miss a lot of the learnings and the development that
Hmm.
happens in the
Yeah.
process. Um,
Yeah.
and I think part of the patience is also being easy on yourself because I
Yeah.
think sometimes you can push so hard to achieve certain results, and you just sort of miss the forest for the trees. And just being able to be patient when you don't hit those, because I can tell you, as an entrepreneur, like we almost never hit a
Right.
lot of our goals and targets. Just things happen
Yeah.
in a way that you never plan or anticipate.
Absolutely. Me and my husband have a term where we're not even type A's. We're all type A plus plus.
Right.
It's like type A is what we were in med school. Maybe now we've advanced from that, but you're right. Patience is the key.
Yeah.
Beautiful. Okay. Moving on to a bit of a rapid fire about your personal choices. Your
Sure.
favorite book.
The Alchemist, Paulo Coelho.
Okay. Yeah. Yeah. Wonderful. Favorite leader. Well, how many times have you read Alchemist?
Probably about 10 times. And so the
10
interesting
times.
thing is we used to, in the early days of Broadreach, we have a copy
Mhm.
of The Alchemist. to everybody who joined. And we also gave a
Oh.
copy and linking with a business book. And the whole
Mm-hmm.
idea was that to do this type of work, you have to lead with both your heart and your brain. So sort of like the business book was the brain, and the Alchemist was about the heart and the passion and the like column.
It's great that you say that, because I feel like a lot of our society these days are working on numbers and Excel sheets. And I think we're losing the humane and the heart part of what we do. And that's not good. And I personally don't like that at all. So
I agree.
anyhow, right. Your favorite leader, John?
Nelson Mandela, because I'm actually going on an airplane tomorrow to go to South Africa. So.
And your favorite study? I know it's an unfair question. Like maybe it's a health policy or public health study, like a clinical trial, a research study.
I can't quote one off the top of my head, but there have been, like when we were doing this study we just kicked off on the evaluation of Social Health 360, there's been some interesting studies that talk about social determinants of health. There's a whole bunch. I can't pick the citations off the top of my head that link them to health outcomes.
Your favorite restaurant in Zurich, Switzerland?
Actually, it's not in Zurich. It's actually in the mountains. It's called Das Elephant. It's actually on the top of the mountain.
Does it have a cuisine?
Yeah, it is sort of like a Swiss European.
Okay.
So they have like really nice versions of like schnitzels and different things like that.
I only know Lindt chocolate and Swiss cheese from Switzerland. So
there's a lot better chocolate. You have to come and visit. We have Sprungli and a bunch of different chocolatiers.
Right. Your favorite ski resort?
Laax. So Laax. That's one that we go to every weekend. It's just an hour away.
Wow. So you and your whole family skis, that means?
Yeah. I mean, there's nothing to do here in the winter. Like it's and there's like literally just hop in the car. It's like 45 minutes, hour away. You can be skiing all day.
Wonderful. A fun fact question about you, John. You are now into American flag football, and very, very deeply so. Please tell us about your journey with American flag football.
I didn't realize at age 54 I'd be playing flag football in Switzerland. So what happened a few years ago was my son noticed a poster in his school asking kids to come out to play flag football. I was like, oh, that's really cool. Like flag football in Switzerland, never heard of it. And so he joined, and then I just started tagging along to the different games. And it's actually a big sport. I didn't realize flag football is one of the fastest growing sports in the world, and it's going to be an Olympic sport in 2028. So anyways, long story short, I started volunteering, and I got being equipment manager, and then they needed help refereeing, so I started refereeing, and they needed help coaching, so I started coaching, and then they needed somebody to be president of the club. Yeah, so now I coach, and I'm now president of the club, and we've got a masters team now, so we're in our second year with the masters team. So a bunch of dads who sort of put the team together. So we compete nationally in Switzerland. So we've got a big competition tomorrow in Basel. Yeah, so it's been a lot of fun. It's just I spent all my time there. I spent a ton of time with my son because of it.
It's funny how your kids drag you into things you've never imagined you would be doing, and then all of a sudden you are refereeing and coaching, and you're now the president of the club. That's
exactly. But it's good fun.
Yes. Okay, my last question for the day. If you were to relive your life, would you become a physician and a technologist?
Absolutely, especially in this day and age. And the reason is because this whole idea of the fourth industrial revolution, like this is the time to be alive. We in oncology, just think about how AI, precision medicine, precision oncology is going to completely change over the next 5 years. What's going to happen in 10 years? This is the time, I think, to really, if you care about helping people, I think the power and ability to help as many people as possible.
Beautiful. Thank you. Well, that is all for today, folks. So the key takeaways from our conversation today. Number one, there are MDs who are helping patients by pursuing their passion around technology. So not everybody is in the clinic, but that doesn't mean that you can't help people and patients all over the world. Precision management is something that was fascinating to me personally, because I feel like a lot of the work that we do in our little clinics or bigger centers, we do have a lot of wastage of resources. And I wish we could utilize them in a more precise sort of a fashion, so where we waste less and utilize more. And then last but not the least, I think I've said this before, I feel like a lot of community and rural practices in the US face the same challenges or similar challenges that we are facing in low middle income countries. So I think the learning has to be both ways. Like we have a lot to learn in the States from these LMICs and technologies like Dr. John Sargent's broad reach group, etc. So as to fix some of those challenges that we have here in our rural and remote practices in the US. And that is all for today, folks. Thank you to our viewers and listeners. This is Jasmine Kamboj and Dr. John Sargent signing off on behalf of OncoDaily from our conversation on Empowering Oncologists. And now you can log on to Empowering Oncologists playlist on YouTube so you don't miss an episode. Thank you so much, Dr. Sargent. Thank you to our viewers and listeners. Thank you.
Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.